notes. So I wanted to welcome everyone this afternoon to Ramona's presentation, How Understanding ACEs, which are Adverse Childhood Experiences, and Trauma-Informed Principles Can Help Children, Families, and Communities. So a couple of the notes that I think now is a good time. This presentation will be recorded. You probably saw that when you came in. There will also be a link that will be available for the recording on YouTube, and I will put that on our Facebook page. But if there is anybody who does not use Facebook, they are more than welcome to email me for it, to request it, and I will put my email in here just in case anyone didn't see it with the Zoom info invitation. If you would like, anyone who might have missed it, if you would like to introduce yourself via the chat, that would be great, and a little bit about maybe where you work. And we're hoping there will be time for questions at the end. And I thought I'd introduce Ramona by reading a bio of hers. So Ramona Danielson PhD MS is an assistant professor in the Department of Public Health at North Dakota State University. She has 22 years of experience in applied social and public health research and evaluation. Her expertise include health equity, maternal and child health, adverse childhood experiences, and social determinants of health. She is an ACE interface master trainer. She has experience collaborating with several tribal nations in the upper Midwest on maternal and infant programs, building capacity around research and trauma-informed approaches and self-healing communities. She teaches graduate courses in NDSU's American Indian Public Health Subplan Certificate and Maternal and Health Subplan Certificate. Welcome, Ramona.
Thank you very much. I'm enjoying seeing people introducing themselves. Great representation across the state and lots of really important work happening with children and families across the state and communities. So I am going to share my screen. It's a little mess. Figure this out. Okay. Are you able to see the full view, not the slide view?
I think so.
Okay. 1 second. Clear my throat. So I'm really excited to be here for this Lunch and Learn for the National Child Abuse Prevention Month, and appreciate being hosted by Prevent Child Abuse North Dakota. I think some of you have heard me speak before, and some of you know me. And even if you've heard some version of me presenting before, I generally get positive feedback that you learn something new, even if you've heard me before. And I do always focus for each presentation that I'm doing. So my focus here is really about how understanding ACEs and understanding trauma-informed principles can really promote thriving for children, families, and communities. I'm going to start with a little bit of engagement, helps me to kind of get to know where everybody's at, but this is also just to get you onto this platform. It's menti.com. You can type it into your web browser or into your phone, Google, and you'll enter the code. So I'll pop this into chat. You'll enter the code 34230866. And I'm also going to copy this direct link here. And so this is going to come up as just a word cloud. So thinking about yourself and how you manage your stress, just in 1 to 2 words, what helps you with your stress? And we should see this populate live as people put answers in. There we go. We see lots of different types of exercise, volleyball, lifting weights, quiet time, controlled breathing, time with horses. That went somewhere. I know I saw that. Sharing and connecting through through work, like reflective supervision, sharing with friends, being with family, relaxing activities like wine and hot tubs and reading, naps, gotta love naps, just that being present and deep breaths, prayer. So you see a lot of different strategies that we all use to sort of help self-regulate. I'll give another minute here for people to finish putting in some of their ideas. And maybe this will give everyone some other ideas of things they can do to help with their stress. I know for us, we're entering our last 2 weeks of the semester in our MPH program. So definitely need to be conscious about some of these self-care activities. So our next question is, what do you see as the biggest challenges facing families in your community? And if you work directly with families, you can think about your clients, the families of students you serve, or just your broader community. And this is going to be more of a short answer. This will come up as, a lack of resources locally. Generational trauma, lack of resources specifically for mental health and medication, perceived isolation, lack of childcare, bullying, easy access to drugs, not having transportation, lack of support, economic development, social determinants of health, historical trauma, structural racism. Resources and isolation. A lot of these, I'm not going to be talking too much about social determinants of health, but I definitely recognize a lot of these external factors that influence the well-being of our families. And then aspects that relate to trauma and those intergenerational impacts, addiction. Thank you for those who are popping in their ideas here. And feel free to finish a thought if you are still typing. And my last question before I get started, what do you see as strengths of the communities that you live and work in? Oh, I was on mute. Thank you, Jacob. So I was reading these out loud. Hopefully you were reading them as well. Resiliency, friendship, perseverance, those family strengths, traditional values, communal support systems, quality schools, wraparound services, more as a need when they exist. They're definitely a strength. So a lot of relationships and a lot of those external factors like the school quality and those resources and wraparound services. So, all right, thank you all for taking some time to reflect on those with me, and we're going to be touching on a lot of those topics in the presentation. Okay, so I'm going to be starting with a discussion about 4 R's of trauma-informed approaches. I'm going to tell you what these 4 R's are, and then we're going to discuss what each of these are throughout the rest of the presentation. And my contention is that trauma-informed approaches are extremely beneficial for families who are experiencing strain, whether or not they have an explicit history of trauma. But I also feel that any communities that are experiencing significant health disparities are communities that have experiences of trauma, whether that's through racism, federal policies, just the challenges and violence that can come with impoverished communities and communities that are lacking resources. So my contention is that trauma-informed approaches should be the default approach that we all take, because really it doesn't hurt anyone, and it's going to benefit everyone, and it's going to be particularly beneficial to people who are most vulnerable, who have had significant experiences of racism, historical trauma, childhood adversity. So the first R is to realize the widespread impact of trauma and understand potential pathways to recovery. The second R is to recognize the signs and symptoms of trauma among people in our lives. Next is to respond by integrating knowledge about trauma into policies and practices. And last is to resist re-traumatization, and that's to actively resist triggering trauma reactions. And if I can ask if anybody isn't on mute, if they can go ahead and put themselves on mute. Just a little background noise, thank you. So there is going to be a wide range of knowledge of people on this lunch and learn. So lots of people are really well versed in the science of the adverse childhood experiences study, and are working on protective factors and thriving communities. And so some of this might be review for those people, but then there are other people still for whom this is completely new information. And so it's important to touch on some of these key factors. And if anybody wants to know more, I mean, I can do an entire day training on the material that I'm going to try to cover here in the next 30 minutes. So here we're starting with realizing the widespread impact of trauma and understanding those potential pathways to recovery. And so the original ACE study conducted by Dr. Robert Anda with the CDC and Dr. Vincent Felitti with Kaiser Permanente in San Diego was in the mid-1990s. They called it the Adverse Childhood Experiences Study, and we often refer to the 10 types of adverse childhood experiences, or ACEs, that they looked at still when we're exploring ACEs today. So for example, the CDC's Behavioral Risk Factor Surveillance System is using the same type of categorization when they're exploring people's adults, generally their experiences of adversity as children. And so those tend to be abuse and neglect, emotional abuse, physical abuse, sexual abuse, emotional and physical neglect, as well as household challenges. And those include domestic violence, having household members that abused alcohol or drugs growing up, having a mentally ill household member, caregiver, parental separation or divorce. And you can think of that as kind of a representation of both the stressful dynamics that might have been in the relationship and in the home prior to separation, as well as that disruption to caregiver relationships. And then also criminal behavior, as evidenced by having a household member who's been incarcerated. And when they looked at the original population in San Diego of about 17,000 people, 1 in 8 of that population had more than 4 ACEs. And so there's a lot of data about sort of how common ACEs are, people having 1, 2, or 3, but it's really when we start getting up to about 4 ACEs that we start seeing some of the biggest impacts on long-term outcomes. And people with 6 or more ACEs, they found in their research that people with 6 or more ACEs were dying on average 20 years earlier than those who had no ACEs. And so that accumulation of ACEs is a really significant piece of what the ACE study discovered. And when we look at 4 or more ACEs, just a few examples, they found that people were 3 times more likely. So this is a study, generally a study of adults who are looking retrospectively at what happened to them as children, but then they're also able to look at what are their current experiences of health and other challenges in their lives. So 3 times the levels of lung disease and adult smoking, and 14 times the number of suicide attempts, 4.5 times more likely to develop depression, 11 times more likely to have intravenous drug abuse, 4 times more likely to have begun sexual intercourse early, and 2 times the level of liver disease. And you can attribute some of that to, okay, they're more likely to be drinking, they're more likely to be smoking, but even in the absence, like if you control for those factors, what the science is telling us now is it's likely a factor of the inflammation that comes from exposure to chronic stress, toxic stress, and sort of these being bathed in stress hormones like cortisol that cause higher rates of heart disease and cancer among people with higher ACE scores. And this is a former president of the American Academy of Pediatrics who lots of public health professionals agree that adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And of course, many of us on this call today are among those who are trying to address this threat and improve the well-being of our children and families and communities. This is a graphic from the CDC that just illustrates the many different areas of our lives in which early adversity can have those lasting impacts. And that's everything from traumatic brain injury and fractures and burns to those mental health issues, including anxiety as well as PTSD, maternal health, including unintended pregnancy, pregnancy complications, exposure to infectious disease, more chronic disease, as I mentioned, more risky behaviors through alcohol and drug abuse, unsafe sex and early initiation, as well as impacts on opportunities, or achieving a higher education, achieving occupational satisfaction or higher income. And one of those ways in which those impacts happen are through, for example, higher prevalence of having work injury or illness, or having missed at least 15 of the last 30 work days due to mental health. So what is unique about the ACE study, what it originally contributed and sort of what many of us take for granted now, is this concept of a dose response relationship. And so you can say, well, there's all kinds of different adverse childhood experiences, why those 10? And part of it is just because those 10 were sort of broad enough that they captured a variety of the experiences that that children are exposed to, and those experiences tend to co-occur. And so, there are all kinds of fields of study that are looking specifically at what does sexual abuse do, to male children as adolescents and female children, pre-adolescent. There's a lot of very specific research questions, but from a population level, you can look at how just the accumulation of ACEs is associated with these long-term outcomes. And so many of you are familiar with this part, and this is where things, when we first started talking about the results of the ACE study, it's like, this feels really heavy, it feels really depressing. And so the field continues to move more towards, okay, well, what can we do about this? And that's going to be the focus of most of what I talk about. But this is just an example of all the different places where this dose response is seen. So for example, higher ACEs are associated with higher rates of asthma, higher rates of the need for mental health treatment, much higher rates of homelessness, as I mentioned, disruptions to work. And so just briefly, to help explain how these experiences can have such a long-lasting impact on our lives, I want you to just think about two different worlds. We'll call the top world here in the orange, the malevolent world. This would be a mean and dangerous world for a child. And we call the trauma and the continuous stress and the recurring unpredictable stress that children are exposed to toxic stress. You heard me use that term earlier. The bottom world is the benevolent world. It's kind and generous, and children grow up free from toxic stress. That doesn't mean they're not experiencing stress, but it's not toxic stress. We're really only made to be under stress for about 20 minutes at a time. And a growing brain that is exposed to sustained danger, like the abuse and neglect and chaotic relationships that I was talking about, that brain is then exposed to stress hormones that are continuously produced, and it results in predictable patterns of brain architecture and behavior and traits. And in effect, the brain is preparing itself for living in a dangerous world. And the characteristics that it's developed, like being hypervigilant and hyperreactive, are actually extremely adaptive in the world that they find themselves when they're, experiencing challenges to their survival. And so it is really important to realize that these are adaptations to their experience. Unfortunately, those adaptations, one, can have these long-term health impacts, and two, can also make it extremely challenging to try to function in the benevolent world. So when we are in a classroom and there's a lot of noise, and you've been seated at the front of the room and there's a lot of people at your back, and there's a, sudden movements and the hypervigilance that a child has developed to be successful in a malevolent home environment is not going to serve them well at school, for example. And this is just one of those powerful illustrations about what is happening that gets wired into our brain as it develops. So what's happening in our lives becomes wired into our brain. And the brain on the left is this healthy brain. It's a PET scan of a normal child experiencing normal levels of stress. And you see all this activity in their temporal lobes. And the brain of an abused, neglected child on the right. And just visually, you see that there's not that much activity in their temporal lobes. And there's a lot of really fascinating brain science that talks about, changes to the amygdala and the hippocampus and prefrontal cortex, and a lot of really interesting information there if you want to know more about it. But it's just explaining how these experiences become part of our physiology. And so this leads us to our second R, which is recognizing signs and symptoms of trauma in people in our lives. And so just some examples, our perceptions. Are we able to ignore loud noises and other things in our environment that other people might simply filter out? Are we constantly on the lookout? How are we appraising things in our environment? Do we see them as threatening when others would just see them as neutral? And what is our emotional reactivity? We might be reacting very quickly and intensely with negative emotions. It can be harder to get back to sort of that neutral baseline level. On the other hand, it can also look like numbing, where we're avoiding triggers or seem really detached or don't have a lot of emotions. You also see behavioral reactivity, maybe being more likely to engage in dangerous behavior, or maybe find it harder to engage in something that is perceived as dangerous. And then just even the coping strategies that we choose and the kind of decision making that we're making. And so we see these, for example, also like just cognitively, it can make it harder to make meaning from language. There can be attention problems, poor verbal or memory recall, difficulty with rational analysis when you're really activated. Relationally, maybe poor self-control of emotions, more difficulty modifying our behavior in response to social cues, which can make it harder to navigate relationships and can lead to social isolation. And so we think, a lot of this, we're talking about how we see these impacts among adults, but those of you who are working, with children as clients now or with families, the impacts are evident as a child develops. So as I mentioned, some of that slowed language development, and the attention problems and small amount of stress being experienced as a crisis. And where you really see impacts over time are in those executive functioning skills. And it can be really interesting sometimes to do a assessment of some of our executive functioning. I know the first time that I did this assessment gave me a lot more self-compassion about some of the executive functioning areas that I wasn't as strong in, to realize that there was this connection to childhood adversity. And that's part of the power of the ACEs research is both that sense of increased compassion, I think, for yourself, but also as you start to realize how that's impacting the other people in your lives, your coworkers, your neighbors, your your clients. I don't do the assessment, have you calculate your own ACE score in smaller sessions or shorter sessions like this, but we do know that ACEs are common, and then we do also know that they're higher in some groups than others. So these are just screenshots from Menti slides from two other presentations I've done. One is an ACE score of the audience of NDSU College of Health Professions students when I did a grand rounds presentation for them. And you had a really high proportion of students there who didn't have any ACEs, but you still had about that 16% with an ACE score of 4 or more, these last two columns. But, these are our future nurses, respiratory therapists, pharmacists. And some of the comments that I got when I did this presentation was that people had no idea that they had classmates who would experience these types of things. And also then just wouldn't necessarily be at all aware that the clients that they're going to be working with are carrying these experiences with them. And these are ACE scores of an audience of early childhood social workers and teachers. And here in this group, because a lot of us are drawn into fields sort of based on some of our personal experiences. And so in social work, and you're drawn to be in the helping professions, here you have double the percentage of the audience who had an ACE score of 4 or more. If you look at any group of people who are homeless, who are incarcerated, you're going to find a much larger proportion of those people who have very high ACE scores. This is some data coming from the National Survey of Children's Health. North Dakota is one of the states that had a large enough sample size that we could look at the data for American Indian children as well as white children. And it's really the first survey that I know of that looked at, I guess what we called them was adverse childhood and family experiences of people who were children at the time. So this is parents reporting on their children. So this survey does not ask them about, is your child being physically or sexually abused? So they get at it more through those household dynamics and some of these other dynamics in the community, like victim of neighborhood violence. And what you see in ACE scores is that they really can reliably predict higher rates of challenges as an adult, which then in turn becomes the basis of the ACE score for the next generation. So here we have a child experiencing divorce or parental separation. Well, that is something that the adult is bringing into that child's life. Same with a child experiencing alcohol or drug problem in the home, or mentally ill or suicidal person in the home. So these are parents self-reporting these dynamics that a child's being exposed to. Part of what I think is really powerful about this analysis is, one, it's showing us a picture of what North Dakota children are experiencing in their homes and communities, and that there is a huge gap for white children compared to American Indian children. So in the graph on the left, that dark green bar is representing American Indian children, and they are significantly more likely than white children to have had many of these experiences. But one thing that I want to point out is that this analysis I did with Dr. Kenny and Devaya Mukatira. Dr. Kenny works for HRSA, Devaya is with the Department of Health. And she did another analysis of all of the data across the nation, and she adjusted for socio-demographic factors, meaning factors related to income, factors related to education, the things that I mentioned at the beginning that really are more about social determinants of health. And she found that the majority of the elevated risk among the American Indian children in this survey could be accounted for by family, neighborhood, and residency factors, which means that it's important to remember that race is a proxy for sort of encapsulating the challenges, the additional challenges that a community is facing. And in North Dakota and across the United States, Indigenous people are experiencing the impacts of historical trauma. And I have some other slides that talk about more about what that historical trauma, how that can impact the day-to-day lives of people. And another factor just being racism as an experience of trauma as well. On the right, this graph is showing that among children 0 to 9, here we have 28% of the American Indian children who had experienced 2 or more of these. And by the time we get to 10 to 17, we're at 74% who'd experienced 2 or more. So this data shows why we get excited about programs like maternal and infant early childhood home visiting, because it's a really important window of opportunity for working with pregnant women and with families who have young children, where we can interrupt that intergenerational transmission of ACEs. And programs like home visiting, which I'll be talking about a little bit later, part of what they're doing is they're helping connect families to resources. They're helping be that support to families. We have Amy Gorno on this call, and she's doing amazing work with the Turtle Mountain Home Visiting Program, which is one of the programs PCAN partners with in the state to administer some federal funding for home visiting. And so partly when we talk about prevention, like ideally we want to get to 0 ACEs, absolutely. But we also want to recognize that, the difference between, having 2 ACEs among 28% of children versus 74% of children is significant. And I don't have the 4 or more data, but the difference when you see that dose response, the difference between having an ACE score of 2 and an ACE score of 4 can be really significant in the long-term well-being of that child. And so prevention is also like preventing further accumulation. That's just a point I want to make sure. Oh, there's our window of prevention and intervention. This leads us to our third R, and this is the respond by integrating knowledge about trauma into policies and practices. And this is a really important point. Risk factors are not predictive factors because of protective factors. So protective factors can include everything from secure housing to meaningful and secure work, cultural connections, safe and stable communities, our individual capabilities. What we think about when we think of protective factors is buffering. And so this is a graphic that explains how the severity, the duration, how your body responds, how quickly you return to baseline, all of that is impacting sort of the difference between whether an experience of stress is tolerable or toxic. And so, as I mentioned, being on that benevolent path on the bottom of that one image, it doesn't mean you're absent of stress. We need, at the very least, mild, brief, exposures to stress. It's very normal, it's healthy, and it helps us build our own resiliency. Tolerable stress is serious, but it's generally short term. And when we have sufficient buffers, which is generally in the case of having a competent adult relationship in our life, that can be the difference between whether that's experienced as positive stress or toxic stress. And then you have those experiences that are pretty much always in the toxic stress category. However, protective factors and buffering can still make a significant difference in terms of the well-being of children and families. So as I mentioned here, supportive relationships with adults can restore physiological changes back to baseline and improve outcomes for the child. But the same dynamic applies to adults as well with high ACEs experiencing stress. So I'm going to talk briefly about some research that Laura Porter, who is part of the ACE interface group that PCAND has brought to North Dakota and has done the master training that I'm a part of. In their behavioral risk factor surveillance system, they added in some protective factors and did some exploring to see if they could understand, what makes a difference. And so they explored help that helps. These are all better, even, they're more powerful when you have more than one of them, but they're feeling social, emotional support and hope, having 2 or more people who help. And that's the idea of like concrete support if you really need some help. Community reciprocity in terms of watching out for children, intervening when they're in trouble, doing favors, and then also social bridging, which is that ability to reach out outside of your social circle to reach out for help. And so this is just the results of one particular examination of the outcome of having poor mental health for more than half of last month. So it's the types of questions, how many days of the last month have you had poor mental health? And, you answer that question. And then they ran that against the sense of support that you have. You usually always feel socially and emotionally supported and hopeful. And then they looked at that by ACE score. So when you look at the blue bars, these are people who say, I don't generally feel that I'm supported or hopeful. And that's a difficult experience for anybody, including people with 0 ACEs. And so when you look at those people, you're at this 15 to 20% who are experiencing poor mental health for more than half of the last month. But by the time you get up to those people with very high ACE scores, you see that dose response. Now we're up to the, closer to 40, 45%. When you layer in a high sense of support and hope, you see a tremendous benefit, to the people with 0 ACEs, but also to these people who have high ACE scores. Oops. And so when you have high ACEs, but you do have that sense of high support and sense of hopefulness, there's much better outcomes. And so I think that's a really important piece of hopeful news for all of us. And then that's kind of what we're going to be talking about now, is sort of how do we build this for ourselves and for the people we work with and for our communities. And so you see these kinds of concepts rising up in a lot of different places. This is the 4-H thriving model for positive youth development. And they talk about what youth thriving looks like. This was some research done at Oregon State University. And they talk about a thriving child as someone who has openness to challenge and discovery, a sense of hopeful purpose. They have awareness of, generally some kind of faith or spirituality or sense of purpose bigger than themselves, a pro-social orientation, positive emotionality, intentional self-regulation. So in general, they're looking to foster this among all children. And they're saying that this comes in the context of sort of these things that children are really excited about, a sense of belonging, these important relationships and engagement. And, then you do these activities for things like what 4-H is doing, and you will have better developmental outcomes and have these better long-term outcomes for children. Some of their research is drawing from the Search Institute, which is actually based out of Minneapolis. And this is research I've been exposed to and have been following and really, really appreciate for a very long time. They used to just talk about developmental assets, and kind of in the context of this continued research on ACEs, they talk about the importance of developmental relationships. And so they have these 5 elements and 20 specific actions that can foster positive relationships that in turn will foster resilience and thriving. And so, they're focused on youth, but as that illustration about mental health and adults with high ACE scores, these are things that we can all be doing for one another. So show me that I matter to you. Listen, believe in me, encourage me, push me to get better, stretch, hold me accountable, help me reflect on mistakes, provide support, help me complete tasks and achieve goals, empower me, stand up for me when I need it, treat me with respect and give me a say, share that power, collaborate, let me lead, and expand possibilities, connect me with people and places that broaden my world. So you can see how those are really significant buffers for youth. Their research is showing that out of the 40 developmental assets that they talk about, and it's things like feeling connected, potentially being, engaged in school extracurricular activities or being engaged in a faith community. There's this range of 40 developmental assets, and kind of like the dose response of the adverse childhood experiences, it isn't so much which exactly you have, but this cumulative protective effect. And so the more assets you have, the less risky behaviors. This is research with thousands of youth. There's 121,000 youth. They're less likely to be involved with substances, sexual intercourse, antisocial behavior, violence, eating disorders, depression, suicide attempts. And conversely, the more assets you have, the more thriving behaviors they see: succeeding in school, helping others, maintaining good health, delaying gratification, some of these executive functioning things, overcoming adversity. And so here's another framework, and really what I'm doing is showing you that there's no one definition of what protective factors look like and what strengthening families look like, but there's a lot of really good work out there. And if you see something that sort of really resonates with you and like seems like it works best for your particular environment, that you can dig deeper. And so the pathway to improved outcomes for children and families looks at how we want to build the protective factors for families. And you'll see some familiar concepts here: social connections, knowledge of parenting and child development. That's a big piece of home visiting, concrete support in times of need, social and emotional competence of children. And when you do that, you see these reduced likelihood of child abuse and neglect, strengthened families. What's important about the rest of this model is that focusing on families is really sort of the downstream part. We also need to be looking at programs that serve children and families. We need to be looking at the practices within the workforce, and further upstream, looking at our state and agency and program leadership in our systems. So we want to be shifting our organizational culture to values that build on family strengths, that we are implementing actions that support families in building their own protective factors, that our workforce has knowledge of protective factors, that they change how they're working with parents. And then in our systems, that we're continuing to deepen our knowledge and understanding, that we are shifting our practice and policy and systems, and that there's a system of accountability. I'm going to go a little faster in a couple of these slides, but here's some everyday actions in each of these areas of protective factors that Strengthening Families model talks about. You can, how do parents manage their stress effectively? You can do that by modeling. Here's what I do. Work on creating inclusive environments for social connections. We can model developmentally appropriate interactions with children. We can talk about connecting families to the resources in the community. That's both that social bridging and concrete support in times of need. And also really helping parents better understand, what nurturing support looks like, how to handle their own emotional reactivity, and in turn help to build their children's social and emotional competence. And all of that is on the pathway to optimal child development, strengthened families, and reduced likelihood of child abuse and neglect. Some other examples, this is coming from a nice CDC infographic, actually, I really liked it, but they're talking more about the systems level work, about strengthening families' financial stability. Some Some of you talked about some of those challenges, you know, including, you know, basically access to childcare, transportation. Here they're talking about paid time off, flexible and consistent work schedules, promoting social norms that protect against violence, really helping kids have a good start, teaching healthy relationship skills, connecting with activities and caring adults, and intervening to lessen immediate and long-term harms. And again, as I mentioned, when you're intervening in a multi-generational program, like something like home visiting, you are also preventing future accumulation of ACEs. I did want to make a special point about children with special healthcare needs and children with disabilities. Basically, children with special healthcare needs are at least 3 times more likely to be abused or neglected, and they are more likely to be seriously injured. And that risk varies by the type of disability. It also varies based on family and parental risk factors, child and disability risk factors, risk related to whether they're, you know, in institutional or non-familial settings. And so this is another group that we need to specifically think about in terms of providing families the resources they need, both to learn the skills that will help them respond to their child's specific needs, and also, you know, the services that they need to help their children thrive. And what we're really talking about is promoting healthy individuals within the context of healthy communities. And I love this particular image, that when a flower doesn't bloom, you fix the environment it grows in, not the flower. And you can think of that immediately family environment, but our community and our systems are that environment as well. And we talk about the importance of fostering thriving communities, and that includes, you know, spiritual and cultural processes as well. Some of the work that I've been a part of with Jacob Davis, who I believe is on this call as well, with some of the tribal communities here in North Dakota, is really fostering self-healing communities. And by definition, self-healing communities, this is actually coming out of Laura Porter's work as well in Washington, is really about implementing trauma-informed components into the work that we do with communities, and recognizing that communities are the experts in their own challenges and solutions. And you know, the system that we've had of like coming from the outside, thinking that, you know, that people from outside the community know what the solutions are, that's really not, we've got a lot of evidence that hasn't worked particularly well. So there's a lot of really good work and positive outcomes coming from where, you know, inclusive leadership, community capacity building, really building that understanding of adverse childhood experiences and those impacts of historical, intergenerational, contemporary trauma, making sure that solutions fit the community's resources, really focusing on strengths and nurturing those feelings of hope and efficacy. And another one of those quotes I really like, shouting self-care at people who actually need community care is how we fail people. Just a couple of brief words about the final R in the 4 R's of being trauma informed, and that's to actively resist triggering trauma reactions. And so this is an example from healthcare settings, and healthcare providers can say, you know, we're here to help, we're working really hard at helping. How can you tell me that our environment is triggering or re-traumatizing the people that we work with? And if you think about, you know, I've seen this firsthand with my mother as she went through cancer treatment for stage 3 breast cancer in both breasts in her mid-50s. And she has an ACE score of 10, and she could not walk into the waiting room of the oncology department without basically sobbing. So without the you know, the assistance of concrete support and some other relationships in her life, it would have been very difficult for her to access and navigate this helping environment that she was in. And that included, the medical procedures themselves, the sounds, really the sense of lack of power, this difficulty when you're triggered, being able to really even process what's being told to you, and make decisions about your treatment, and also just sort of feeling invalidated. Like if you're emotional, then, they're going to, discount you. And so, some of you might recognize that this happens either in yourself or loved ones, or you've seen it in the helping environment that you're in. And so this is just an example of the types of things that cause re-traumatization, both on the systems level and the relationship level. Having to continually retell your story, having to disrobe, being seen as your label, not having choice, not being able to give feedback. On the relationship level, when it's not collaborative, when things are being done for you, when things are punitive, when your sense of trust is violated. Those are all examples of re-traumatization that we want to avoid. So the core principles of a trauma-informed approach, and this is where I invite anyone who's interested, that this is where you dig deeper. We can't possibly accomplish all this in a single lunch and learn, but you'll see a lot of these ideas in the self-healing communities and in just sort of what helps, and that's the safety, that sense of safety, both physical and psychological. Being trustworthy and transparent, that's that peer support, collaboration, shared decision making, empowering people, and having both humility, cultural humility, and being responsive to the needs of the group that you're working with. There are some really great resources out there. This, for example, is a guide to trauma-informed organizational development. Examples of a checklist of what you can do for your outside environment. For example, the area around the program and the front door is well lit, the parking lot is well lit, what you can do in your lobby and your waiting area, that background sounds are at a low level, that it's well lit, that there aren't overpowering smells. You just think of literally this physical environment that somebody is encountering. And then also policies and procedures checklist. So for example, a written or statement policy about a commitment to understanding trauma, on the need to account for consumer experiences, allowing grievances and incidents to be reported, etc. The CDC created a technical package on preventing ACEs. It's a great document that goes into each of these areas. You're kind of introduced to these briefly earlier. And I kind of starred some of the areas that programs that PCAN implements in North Dakota are relating to. So for example, public education, like this Lunch and Learn and the Master ACE training program through ACE Interface, and the work of the North Dakota Child Sexual Abuse Prevention Task Force. We have the evidence-based home visiting here, that multi-generational approach to really build parenting skills, connect families to resources. You have programs like Period of Purple Crying, which is really about building parenting skills, and also programs like Handle with Care that I know is being implemented or being expanded. And that's a really exciting program where, the idea of making law enforcement and maybe some of these other helping environments more trauma-informed and victim-centered. And it's important when you're working with people who have a trauma history, people are like, I'm more than just what happened to me. I'm not just my trauma. And so as a field, we continue to try to figure out how to talk about things. And so trauma-informed approaches kind of sound negative, but they really are strength-based approaches, and we don't have like a great other term for them. But the focus really is on being healing-centered and, not just surviving, but thriving. But it's really also about just kind of changing the way we think about people, from like what's wrong with you to what has happened to you, and also what's right with you, that strength-based approach. I'd like to invite everyone to go back to Menti briefly and just share one or two words about, how you're feeling about what you learned in this presentation, any kind of aha moments. And that link is in, let's see if I can get to the next one here. Yep. Okay. So I think actually the first one is, what are 2 to 3 things that you see yourself sharing with others? And this would be just a brief phrase as you come up with those little boxes again. So again, this is menti.com and the code 3423-0866. So just invite a little bit of reflection here. And I've done, unfortunately, not a great job of leaving time for questions within the hour allotted, but I do not have to hop off right at once. So I'm happy to answer questions for anybody who can stay on for a few minutes. And am happy to hear from others. I have a slide with my, I think my email address on it here in just a moment. But so look forward to a couple of reflections here, things that you see yourself sharing with others. Personal journey, how that relates to my understanding of ACEs, feeling hopeful, the high difference in ACE scores between white children and Native American children, and how much the difference increases as they get older. That supporting families economically is actually a method of preventing child abuse. That our past experiences can be affecting our current actions. Absolutely. How you see those differences in scores, thinking about how different those scores can be from one group to another. Generational trauma and ACEs, how we can help both. That there's that connection between medical issues and how that can be re-experienced, re-triggering for trauma, people with trauma. The 4 R's, ACE scores. Need to educate about trauma and ACEs. 4 R's. Let's give another moment as people might be typing. Foster parents would benefit from this presentation. This has been recorded, and I know that Veronica will be making this available. And Veronica, I believe you mentioned that you'd be posting it on the PCAN Facebook page, but also I think you can reach out directly and ask for that if you're having trouble finding it. As far as when it will be available, I bet that it won't take too long. Thank you, Jacob. Link from Veronica to the Strengthening Families document. Thank you.
I would think it would be available today or tomorrow.
Fantastic. And here is just my very last slide where I get to plug myself as a proud Head Start alumna. And my 2 munchkins that I drive a lot of work that I do. And I want to thank Prevent Child Abuse North Dakota both for inviting me and also for bringing ACE Interface. And I know that there's some talk about how that will be rolled out more in North Dakota. So any questions right now? I guess I did put my email address, so feel free to reach out. Feel free to share this recording. It's